Hello everyone, this is your host Mahek Shah. Welcome to a new episode of the HeartSuccess podcast where we discuss practical knowledge and the latest in the field of cardiovascular medicine. All listeners be advised that the podcast is for personal information, education, and entertainment only. Information from this podcast should not be used as medical dictum, and all decisions related to patient care should be made in consultation with care providers.
We will be starting this episode by introducing you to our new heart teammate, Garima Dahiya. Garima will go over two recent trials that were published in the New England Journal of Medicine. The Excel trial that was also presented at the TCT meeting earlier in September, followed by the Polypill trial. After these discussions, I will follow those with three heart failure studies, one on the role of beta blockers in HFpEF, and the other two involve the use of handheld ultrasonography and the importance of using these modalities in our day-to-day clinical practice. I will be discussing important trials that were also presented at TCT, including TWILIGHT, followed by the new study on using therapeutic hypothermia in patients with non-shockable rhythm and cardiac arrest, closing it with CITRIS-ALI, which is the use of vitamin C in primarily vasoplegic septic shock, and use of statins in patients with familial hypercholesterolemia, 20-year results. We learned a lot making this episode for you. We certainly hope that you enjoy listening to this episode and keeping up with some of the latest data being presented. Garima, welcome to HeartSuccess. Great to have you.
It's an absolute pleasure to be a part of the team, Mahek.
So Garima, tell us a little bit about you so our listeners can actually get to know you a little bit better.
I grew up in India in a boarding school, actually in the northern part of India. Mahek and I actually know each other from all the way from med school. So that's where I did my medical training. And for residency, I moved here to Pittsburgh to Allegheny General. And I'm currently in the process of applying for a cardiology fellowship. Just finished my fellowship interviews yesterday. So fingers crossed now.
Congratulations. This is a tough part, but I'm sure you'll end up at a great place and do great things. Garima is actually going to be helping us with a lot of future interviews, so you'll be hearing a lot more from her. What we're going to do today is we're going to talk about a couple of trials with Garima, a couple of trials that came out in the last few weeks, both published in the New England Journal of Medicine. So Garima, why don't you start us off with the Excel trial and tell us what this trial was about.
The Excel trial was an open-label, multi-center randomized controlled trial. It compared outcomes after PCI and CABG among patients with left main disease of either low or intermediate anatomical complexity. This trial was actually recently presented at TCT in San Francisco about a month ago. The trial included about 1,900 patients with left main disease that were randomly assigned to either undergo PCI with a Resilience stent or undergo CABG. The way the investigators ascertained the extent of coronary disease was either they included patients with more than 70% left main disease, or they included patients that had hemodynamically significant 50 to 70% disease. And as far as the anatomical complexity of the lesion was concerned, they included patients with a syntax score of 32 or less. And then they followed these patients up essentially at 1 month, 6 month, and 1 year intervals, and then annually thereafter for about 5 years.
I see. So these are really the 5-year results that came out. When
Right,
you said
yeah.
functional assessment for 50 to 70%, what kind of modalities do we refer to when we say functional assessment?
So it said that they actually used both invasive and non-invasive ways of doing that.
Yeah, so I think this would typically be a combination of invasive testing where you would use FFR in the cath lab and ischemia testing using
Non-invasive stress test. Tell us more about the study, Garima.
So what the authors looked at, the primary outcome of the study was a composite of death from any cause, stroke or MI. They also looked at long-term additional secondary outcomes, which were basically all of these measures and the components again at 5 years. The trial was powered to look at outcomes at 3 years, and the 5-year secondary outcomes were pre-specified, but they were not explicitly powered or adjusted for multiple comparisons. So the results of the studies were as follows. The mean age of the patients was about 67 years, of which 77% patients were male and about 29% had diabetes. And as far as the clinical and geographic characteristics were concerned, they were pretty much similar between the two groups. With regard to the primary outcome, the 5-year follow-up was achieved in about 93% patients in the PCI and 90% in CABG groups. And the primary outcome at 5 years was 22% of the patients in the PCI group and 19% in the CABG group suffered from a death, stroke, or MI. So it was actually an insignificant p-value of 0.13. And this finding was consistent across all the subgroups, including patients with and without diabetes and those with lower or higher syntax scores.
I see. And what about the individual end?
So when the authors looked at the event rates of death from any cause and repeat revascularization, it actually favored CABG. When they looked at event rates of cerebrovascular events, which is stroke and therapy failure, it favored PCI. As far as rates of myocardial infarction was concerned, it was similar between the two groups at 5 years. But it actually favored PCI in the peri-procedural period and CABG during the long-term follow-up. And the authors split their hazard ratio for the primary outcome in 3 distinct time periods for the study. So they looked at the relative risk between the two therapies, that is PCI versus CABG, in 3 time intervals, which is 0 to 30 days, when PCI resulted in fewer primary outcomes than CABG with a hazard ratio of 0.61. They looked at 30 days to 1 year when the primary outcome was similar between, the incidence of events was similar between the two groups with a hazard ratio of 1.07. And between 1 to 5 years, the primary outcome was far less common in the CABG group than PCI with a hazard ratio of 1.61.
You know, one of the other things, as we've noted from all these trials that compare PCI and CABG, especially in left main disease, most of the data consistently shows that patients who do receive PCI end up needing more revascularization down the line, as they did in this trial, I believe. The ischemia-driven revascularization remained more frequent following a PCI than CABG, the absolute difference really being 6.9% at 5 years.
You know, the authors actually said that left main coronary disease in those patients with lower intermediate syntax scores, PCI with these everolimus Zion stents is non-inferior to CABG with respect to the rate of the composite endpoint of death, stroke, or MI.
That was great, Garima. I think this is a very important study, one of the largest studies in this arena. Really, at this point, I think a lot of the larger centers have started using left main PCI. Patients prefer it too because it's more attractive. You don't have to go through open chest surgery, and the recovery certainly is a lot faster after PCI. However, there's still more to learn, clearly.
And, you know, another interesting thing was that, you know, while most of the patients in this study, about 77% were males, but now that we're talking about possibility of non-inferiority of an interventional study, I wonder how it's going to look for women who we know are traditionally poor surgical candidates and sometimes don't end up getting therapy for that particular reason. They just don't undergo a CABG. So I wonder how it's going to pan out, like what sort of gender outcomes we're going to see with regard to management of left main coronary artery disease in the long run.
That's true. That's a great point. Yep.
If you've been online in the last few weeks, you've noted that there is significant controversy surrounding the EXCEL trial. I wouldn't like to go into far too many details of accusations of data manipulation and changing definition for perioperative MI, because we have so far no evidence that any of this is actually true. However, what we do know is PCI and CABG were equivalent in the primary outcome at 5 years, mainly because there was a higher incidence of perioperative MI among patients undergoing bypass surgery. Now, the definition of perioperative MI is what has come to controversy here, and the importance of even defining this specific entity of perioperative MI has been controversial. Concerns have been raised that using a definition of perioperative myocardial infarction, which is based on CKMB elevations post-procedure, naturally expected to be higher following bypass surgery,
clearly tilting the tables in favor of the PCI arm over bypass. The other argument is that peri-procedural MI is probably not as important as spontaneous myocardial infarction, and putting them together in the same endpoint may not be the right way to go.
There is retrospective data that perioperative MI actually predicts long-term outcomes. However, you could argue that if that were actually true, wouldn't these patients with higher perioperative MI do worse or have worse outcomes? Quite on the contrary, patients actually in the bypass arm seemed to do better when it came to mortality as you moved away from the index procedure, and spontaneous myocardial infarction as you moved away from the index procedure. The importance of perioperative MI seems to be overstated, and using it as a primary endpoint in such a large trial is questionable. You would also argue that having a secondary endpoint of mortality, which seems to be favoring CABG with a 3.1% absolute difference at 5 years, and a statistical value that was significant, should make you pause and think about whether you can equate these different primary endpoints and use the same scale to measure them, because for the purpose of the primary endpoint, they're all treated as the same. And I think we all know that mortality is fairly more important than perioperative myocardial infarction. So these are the controversies surrounding this study. Dr. Greg Stone on Twitter has put up several points of data which argue to the fact that this mortality signal that we are seeing among patients in Excel may just be by chance. One, because the study was never powered to study that individual endpoint. Two, he presents a meta-analysis from several other randomized control trials, I think at least 4 randomized control trials, showing no difference in all-cause mortality between the PCI arms and the CABG arms, lending credence to the fact that in this study it could be just chance. I think these are reasonable points. What's happened in Excel has raised an important point that maybe whenever we do studies comparing PCI and bypass, it is very important to follow these patients for a long time, because the benefits of using bypass are clearly accumulated over several years. This study, once they do present the 10-year results or maybe subsequent results in the coming few years, it will be interesting to see whether the curves, which are already diverging in favor of bypass, continue to do so. Because at some point in time, it is very likely that these curves will favor bypass over PCI if they continue to move in the same direction they are currently. On the other hand, it's certainly possible that these curves could move closer to each other as we move away from the index PCI or index bypass procedure. It's just going to be very important to get more long-term data. With respect to the issues on data manipulation or changing of definitions, I think over time we will get a more clear picture of whether there is any validity to these accusations. I think it's not fair to say that either of these accusations are true pending more information coming to us. The trial was sponsored by industry. It was sponsored by Abbott. And honestly, if you look at the data overall, CABG seems to be the winner when it comes to long-term mortality, when it comes to the combination of using death, stroke, MI, or revascularization, when it comes to using death or spontaneous MI, and even when it comes to the primary endpoint, though non-significant, the trend is clearly in favor of CABG. Despite the primary endpoint of the study saying they are equivalent, I think a more nuanced approach does favor CABG over PCI in this study.
All right, so that was our first trial for today. We have another trial published in the New England Journal in the middle of September, and this trial has
far-reaching consequences at a population level. So can you tell us a little bit about what trial and why this trial is so important?
Absolutely, Mehak. The study he's talking about is the Polypill trial, which was a study done to evaluate whether combination medications aid in cardiovascular disease prevention or not. This was a randomized controlled trial involving adults without onset of cardiovascular disease that was done in an underserved population for patients with a low socioeconomic status. This trial was a two-group open-label randomized controlled trial that was done in Mobile, Alabama. It was the way the authors went about it is they identified two of the biggest risk factors for occurrence of cardiovascular disease, which is hypertension and elevated LDL cholesterol levels, more so among patients with a low socioeconomic status. And what they did is they created a fixed dose combination pill of atorvastatin 10 milligrams, amlodipine 2.5 milligrams, losartan 25 milligrams, and hydrochlorothiazide 12.5 milligram. And the hypothesis was that, because of the simplicity of the regimen, it's going to result in more compliance and more patients adhering to it. And as far as blood pressure control is concerned, that it'll improve the safety profile as well, because now we're using multiple low-dose medications rather than using one or two medicines with really high doses. And we know that the side effects are typically dose-dependent. So the authors actually identified patients from a previous study, the SCSS, which is the Southern Community Cohort Study. It was a study that was created in 2001 to study health disparities in cancer in this particular population in Alabama. They identified patients 45 to 75 years of age without any history of coronary artery disease, heart failure, cerebrovascular accidents, or insulin-dependent diabetes, malignancy, or liver disease. But they did include patients who were at least on one or two antihypertensives with a blood pressure of 120 to 160 and an LDL level of less than 190 and normal renal function. So that was basically the patient population that they included in the study. And then the participants were given a 90-day refill supply of this polypill that we previously described, consisting of a statin and these three antihypertensives. We continued to follow these patients at 2 months and 12 months after randomization. Mm-hmm. So moving on to the outcomes of the study, the two primary outcomes that they looked at were the changes in the systolic blood pressure and an LDL cholesterol level from baseline to 12 months.
So what they really used are surrogate endpoints and efficacy endpoints, not really hard endpoints. But we already have sufficient data showing good blood pressure control, good lipid control, and good risk factor control in a population has its advantages for the overall health of the community. Absolutely. Tell us the results of this trial.
That's right. And, to allude to the point you were making, that was the hypothesis is if you target these two, the LDL and the blood pressure, that would automatically reduce their 10-year ASCVD risk and therefore prevent cardiovascular disease in the future. Investigators included about 300 patients in the trial, which 148 and 155 respectively were in both arms. About 3/4 of the patients had an annual income of less than $15,000. So we're talking about like the really low socioeconomic status here. The mean BMI of the patients was more than 30, and 43% of the participants had stage 2 or more hypertension. The mean 10-year cardiovascular risk was 12.7% overall, 12.4% in the polypill group and 13% in the usual care group. And the baseline blood pressure was 140/80 and baseline LDL of about 113. So what the investigators found in the study was that the mean systolic blood pressure decreased by about 9 millimeters in the polypill group compared to 2 in the usual care group, and the mean LDL dropped by about 15 in the polypill group compared to only 4 in the traditional care group. And of course, both of these changes were statistically significant.
That's actually quite a big difference.
Additionally,
the pill burden really is minimal when we're using these combination pills. This is something I do wish more and more in practice, that we had available polypill regimens that were affordable.
and
That's
I
right.
could prescribe to my patients. Unfortunately, that's not always an option available. Hopefully, research like this will generate interest in creating these polypills at a very affordable cost for the community, helping both
Hmm.
physicians and patients.
That's right. It can actually have pretty far-reaching effects because, if you look at the eventual conclusion of the study, they found a 25% relative risk reduction in the estimated cardiovascular risk among the polypill group as opposed to patients who were taking multiple individual medications. So if you look at the overall impact at the level of, at the population-based level, it could have far-reaching consequences, like you mentioned.
96% of the adults enrolled into the study were actually Black. So really this study represents an underserved population in the community that really would benefit from such interventions. Looking beyond the US even, I think using these polypills has a lot of value in some of the lower socioeconomic communities in several other countries with maybe less access to healthcare and an inability to really follow up on a very regular basis with physicians.
And I wonder what consequences this would have even among patients exclusively with heart failure, those who are not of, particularly lower socioeconomic status. We know patients who tend to have, the higher stages of cardiomyopathy, they end up being on multiple medications during that they have to take during a day. As we know, the compliance to meds is inversely proportional to the number of meds they're taking in a day. So I wonder how this would pan out for patients with end-stage cardiomyopathy and, patients who are already on over 5 to 10 medications a day, how a polypill-based strategy would pan out in ensuring their compliance as well.
Absolutely. And one thing that we should mention is that the polypill was very safe. The overall reported side effects in this study, myalgias from statin really being only 1% in the polypill group. And the incidence of hypotension or lightheadedness was also just 1% in the polypill group. So very safe overall and very efficacious as well.
That's right.
Thanks a lot, Garima.
Yeah, absolutely. It's my pleasure. And hopefully we can, keep apprising our audience of what the latest evidence is hopefully on a regular basis. Thanks, Mehak, for having me on the show.
I'll kick off the heart failure section today by talking about this very thought-provoking study that was published in Circulation Heart Failure. It looked at beta blocker use in patients with heart failure and preserved ejection fraction. As you may know, prior studies using beta blockers in patients with HFpEF have shown really no benefit when it comes to heart outcomes. This study was trying to look into possibly harm in using and titrating beta blockers within this population. So what the authors noted was in large recent HFpEF trials, about 80% of the patients were receiving beta blockers, while some patients may have appropriate indications, which is a mildly reduced ejection fraction. In many cases, the indication was either for hypertension, for stable coronary artery disease or atrial fibrillation, for which beta blockers are no longer considered a preferred long-term treatment and have uncertain benefit. The authors argued that in large animal studies and in normal patients or patients with HFpEF when EF was defined as more than or equal to 50%, was there any role for pharmacological heart rate lowering? The authors looked at data on the use of increased heart rate in patients with HFpEF, and they found that the data currently suggests that the hemodynamic effect of increasing heart rate to 120 per minute by atrial pacing had been reported before. Compared to resting heart rate, the LV-EDP significantly decreased at 120 per minute, while end-diastolic, end-systolic, and stroke volumes all declined. Compared with control subjects, as heart rate increased, the rise in dp/dt was blunted, but shortening of tau was preserved. While the acute hemodynamic effects of lowering the heart rate in HFpEF have not been studied, because LV and diastolic pressure declines substantially with heart rate elevations in HFpEF, it is likely that slowing the heart rate, slowing the resting heart rate, will actually raise filling pressures. They also say that increases in heart rate in patients with HFpEF are associated with LV volume reductions that resulted in a blunted heart rate cardiac output relationship. Slowing of resting heart rate would likely modestly actually reduce the cardiac output. The fact that you would get a slightly lower cardiac output and higher filling pressures is obviously an undesirable effect in patients with HFpEF, suggesting that maybe higher resting heart rates provides hemodynamic benefits. Clinical experience with beta blockers in ivabradine, which is a sinus node rate reducer, provides insights into the chronic effects of pharmacological heart rate lowering. What the authors described was prolonging diastolic filling, which happens when you lower the heart rate, actually increases ventricular volumes and pressures, thus increasing the ventricular load. This increased ventricular load actually correlates with the observation that natriuretic peptide levels have been elevated in patients receiving beta blockers in population-level studies. More than one study, including the ELAND study, the CIBIS-ELD study, and the SWEDIC study, which was an echocardiographic study of patients with diastolic dysfunction randomized to either Carvedilol or placebo, where BNP levels were higher with Carvedilol, and patients receiving Carvedilol had an unexpected worsening in heart failure symptoms. The authors raised the possibility that beta blockers exacerbate HFpEF. They also note that worse outcomes were noted in the only two randomized control trials looking at long-term beta blocker use in HFpEF. The Seniors trial, which randomized patients to determine the effect of nebivolol on mortality and cardiovascular hospital admission in elderly patients with heart failure. The trial used an EF cutoff of more than 35% to define HFpEF, approximately half the patients having an EF of less than 50%. Now, although the trial reported benefits in all patients, a recent analysis did not find benefit in patients with EF 50% or higher. Now, the trial was definitely underpowered, it seems, to detect a significant change in patients with a high EF. It is noteworthy that heart failure hospitalizations, which is a key endpoint, was not specifically documented within this group. There was another trial, which was the Japanese diastolic heart failure trial, tested the use of Carvedilol in 245 patients with EF more than 40%. They did not find any beneficial or adverse event even after limiting the analysis to patients with EF more than or equal to 50%. However, the total daily dose of Carvedilol used in this study was only 8.5 milligrams. So that's a very, very low dose.
If we direct our attention to
outcomes following trials with ivabradine versus placebo in HFpEF, it was the EDIFY study enrolling 179 patients with resting heart rates over 70 beats per minute. Using ivabradine, a heart rate reduction of 8 per minute did not improve the E by E prime ratio, which is a representation of filling pressures on echocardiography. It did not improve total walk distance or NT-proBNP levels among patients with HFpEF. So in this study with ivabradine, heart rate lowering with ivabradine really did not appear to provide any consistent benefit. And they said that it is actually concerning that in a much larger trial in patients with coronary artery disease, though without heart failure, a 20% increase in heart failure admissions was observed using this drug. The authors conclude that the weight of evidence obtained from normal subjects and patients with HFpEF indicates that within the physiological range, an acute increase in resting heart rate results in LV volume reduction and lower filling pressures. Pharmacological heart rate lowering in general in patients with normal ejection fraction likely has adverse effects on exercise capacity and outcomes. If you have patients with heart failure and preserved ejection fraction and you're using beta blockers for alternative diagnosis, those really being, like we discussed, atrial fibrillation or underlying coronary artery disease or underlying hypertension, you shouldn't really go to beta blockers as your first-line therapy. You want to use other alternatives that may be reasonable and possibly even better. They end this study with a very interesting point saying that, considering the very high prevalence of beta blocker use in HFpEF, it is unlikely that a large definitive outcome trial can be undertaken at this point looking at the effect of beta blockers in these patients. What is probably more reasonable is to actually do a withdrawal trial where you would take half the patients off the beta blocker and keep the other half on the beta blocker to look at the difference in their exercise capacities, in hemodynamics, and possibly difference in outcomes over an intermediate to long term. Patients with HFpEF have already been associated with having some degree of chronotropic incompetence, so it's also important to realize that putting these patients on beta blockers would exacerbate their inability to increase their heart rates and possibly add to the adverse events that patients from these drugs do face, those being really confusion, fatigue, bradycardia, or even heart blocks in some of the more older patients with HFpEF.
In the last few weeks, there are two separate studies that came out on the use of lung ultrasound in patients with heart failure. This particular study was published in JACC Heart Failure by authors from Brigham and Women's in Boston and Glasgow Cardiovascular Research Center in the United Kingdom. Both these centers conducted a prospective study where 4-zone lung ultrasonography was performed early during the hospitalization for heart failure and then at discharge. They looked at the presence of curly B lines, which you will see on lung ultrasonography, suggestive of the presence of pulmonary edema or lung congestion in the setting of acute decompensated heart failure. And they quantified these B lines offline by people who were blinded to these findings and conducted by a core laboratory. So they enrolled 349 patients, median age 75 years, almost 60% men with a mean ejection fraction of 39%. They looked at 4-zone lung ultrasound. They totaled up all the B lines they saw in these 4 zones and looked at the outcomes. And what they found was very interesting. They found that the odds for each B line tertile at baseline was 1.82 for adverse in-hospital events. The other thing they saw was when they looked at the total B lines at discharge, the risk for heart failure hospitalization and all-cause death was significantly higher in patients with higher B lines at discharge. The relationship was definitely a lot stronger closer to discharge in the first few days, really within the first 60 days, and then it seemed to be less predictive of outcomes as time went on. They did follow these patients for a total of 180 days. So the authors concluded that pulmonary congestion using a simplified 4-zone lung ultrasound method was common in patients with heart failure and improved with therapy. A higher number of B lines at baseline and discharge identified patients at high risk for adverse events. We have been using, I would say, ultrasonography to look at the IVC in these patients. We look at the JVP in these patients. We listen for crackles. We look at pulmonary edema. We look at the bump in BUNs and creatinines and try to really make an assessment whether these patients have been diuresed adequately in the hospital. They've lost some weight in the hospital. And hopefully we've gotten them euvolemic at the time of discharge. We don't always use ultrasonography to look at the presence of B lines, which seems to be a fairly sensitive and specific marker in heart failure patients. And the change in B lines also has been shown in other studies to correlate very well with the volume status. So I think the reason this study is important because I myself have been considering buying a handheld ultrasound machine that I could have in my pocket at all times while I'm rounding in the hospital. And I think it will add a great tool to the other things that I already just mentioned to probably complement these skills in identifying which patients are ready for discharge, and maybe the presence of more B lines on ultrasonography on the day of discharge suggests that these patients are probably still volume overloaded and clearly reflect a higher risk population that is being discharged from the hospital. The other thing is I'm not certain if I'm comfortable looking at B lines, so maybe I would start out early on by just performing it in patients that have clear volume overload, that I know for sure have pulmonary edema to some degree, and trying to correlate my findings with the presence of B lines on ultrasonography and then diuresing them in the hospital, actually seeing how the B lines change over time. I think if I do this enough, and if I do this frequently enough, I'd start getting more comfortable with using this as a bedside tool, and it always gets residents and fellows excited when you're using some of these newer techniques because we know physical examination has its limitations. The handheld ultrasound is an extension of your physical exam at this point. So I was really excited on looking at this study. The other study that used lung ultrasonography in heart failure with preserved ejection fraction patients. And briefly what I'll mention is the lung congestion during exercise in heart failure with preserved ejection fraction is an increase in extravascular lung volume during exercise, which contributes to symptoms and has been shown to predict morbidity and mortality. It is unclear what leads to pulmonary congestion during exercise. One of the thoughts always has been that it's just increased hydrostatic pressure because of back pressure, of increased filling pressures developing in the heart that lead to fluid filtration. But the other argument that has also been made is that it's actually not just increased hydrostatic pressures, but it's systemic venous hypertension due to altered right ventricular and pulmonary artery coupling, which may interfere with fluid clearance and decreased lymphatic drainage. And that's what this study performed at the Mayo Clinic, led by Yogesh Reddy and senior author Barry Borlaug, showed that they exercised 61 patients with HFpEF. These were ambulatory patients who underwent invasive hemodynamic exercise testing using high-fidelity micromanometers and simultaneous lung ultrasound, echocardiography, and expired gas analysis at rest and during submaximal exercise. Without going into too many details of the different hemodynamic changes that occurred, over half of the stable outpatients with HFpEF developed increase in interstitial lung water, even during submaximal exercise. The acute development of lung congestion noted on your ultrasound, really looking at curly B lines on lung ultrasonography, correlated with increases in pulmonary capillary hydrostatic pressure, which favors fluid filtration, but also correlated with increased systemic venous hypertension due to altered right ventricular pulmonary artery coupling that interfered likely with fluid clearance. So it's a combination of both of these, which very likely results in pulmonary edema. This is interesting because, when we talk about right heart failure, commonly we see some pulmonary edema with right heart failure, and then the argument is, if you have RV failure, you shouldn't have any pulmonary edema because that comes only with left heart failure. Well, that's not actually true. And this hypothesis is in keeping with the fact that maybe patients who have significantly elevated right-sided pressures, especially that you would see in some patients with pulmonary hypertension, and then they have coexistent pulmonary edema, it's not because of left heart disease. It's commonly because of impaired lymphatic drainage.
One of the remarkable studies presented at TCT was the TWILIGHT study. Studied ticagrelor monotherapy 3 months following high-risk PCI. This study showed that a short duration of dual antiplatelet therapy, which was basically 3 months of aspirin plus ticagrelor, followed by either ticagrelor monotherapy for 12 months, resulted in less bleeding compared to longer duration of DAP therapy, which is an additional 12 months of patients getting aspirin plus ticagrelor. The ischemic rates met criteria for non-inferiority in this trial. Now, the goal of this trial was to study the safety and efficacy of a short duration of dual antiplatelet therapy, 3 months in this study, followed by monotherapy with ticagrelor, compared to long-term dual antiplatelet therapy among PCI patients. And these patients had at least one or more than one high-risk feature for ischemia or bleeding. The clinical criteria for high-risk bleeding were an age of at least 65 years, female sex, troponin-positive acute coronary syndrome, established vascular disease, diabetes being treated with medications, and chronic kidney disease. Angiographic criteria included multivessel coronary artery disease, total stent length of more than 30 millimeters, a thrombotic target lesion, a bifurcation lesion treated with 2 stents, an obstructive left main or proximal LAD lesion, and a calcific target lesion treated with atherectomy. Patients that were excluded from this trial included STEMI, cardiogenic shock, use of long-term oral anticoagulants, or a contraindication to either aspirin or ticagrelor. The primary bleeding endpoint was a BARC type 2, 3, or 5 bleed, which was significantly lower among patients who received ticagrelor monotherapy compared to those receiving dual antiplatelet. The rate of TIMI minor or major bleeding, or GUSTO moderate or severe bleeding, and ISTH major bleeding criteria were all lower among patients who received ticagrelor compared to dual antiplatelet. On the other hand, the rate of death from any cause or non-fatal myocardial infarction or non-fatal stroke were no different between either group. Death from any cause was no different. Death from cardiovascular causes was no different. Myocardial infarction rate was the same between both groups. Ischemic stroke was also no different, and stent thrombosis, either definite or probable, was also no different in the study. What is interesting in this study is that the randomization occurred at 3 months of dual antiplatelet therapy, which means you selected a group of patients that was probably at a lower risk for bleeding because they had to be on therapy for 3 months to actually get randomized. The other interesting thing about this study was that only 28 to 30% of the patients in the study actually had an NSTEMI. The rest of the patients, 30% had stable angina, 6.5% were asymptomatic, and 35% had unstable angina. I would argue that a lot of these patients don't need dual antiplatelet therapy for 12 months beyond 3 months of treatment with ticagrelor and aspirin. In addition, current guidelines don't support using ticagrelor for stable coronary artery disease or patients with asymptomatic coronary artery disease undergoing PCI. So there is clearly some argument that can be made that the control group to some degree may have been overtreated and may have contributed in part to the high risk for bleeding within that group. When you look at the curves for bleeding, you could see that the curves actually start separating right away at randomization and continue to move apart even at 12 months. So it makes sense that the risk of bleeding on dual antiplatelet therapy keeps accumulating over time the longer you remain on such therapy. There was another study that was presented called Global Leaders. This was a study that actually failed to show that 23 months of ticagrelor after 1 month of dual antiplatelet therapy was superior to standard therapy. The global leader study was a larger study, had almost 16,000 patients, had a total duration of follow-up for 24 months. The inclusion criteria was that the patients underwent PCI with a bioluminescence-eluting stent for stable or unstable coronary artery disease. In their study, there was really no difference in the ischemic endpoints, including myocardial infarction. There was no difference in all-cause mortality. In this study, the primary outcome was all-cause mortality or non-fatal myocardial infarction, which occurred in 3.8% in the experimental group compared to 4.4% in the control group, p-value of 0.07, meaning there was no difference between using either ticagrelor monotherapy or control therapy in the other group. The control group in this study would get either dual antiplatelet for 12 months, which included aspirin and Plavix if they had stable coronary artery disease, or they received aspirin or ticagrelor for unstable coronary artery disease, followed by 12 months of aspirin in both these groups. To some degree, this also represented a degree of overtreatment because for most stable coronary artery disease patients receiving PCI, current guidelines recommend up to 6 months of dual antiplatelet therapy, not necessarily going beyond that in most cases. The authors of TWILIGHT acknowledged that the study results could not be generalized to all patients receiving PCI because the study had very specific inclusion and exclusion criteria, and the results were not applicable to patients receiving background therapy with other P2Y12 inhibitors, nor to those who have events before 3 months, or to those who are non-adherent to ticagrelor and aspirin before 3 months. It is quite important to note that the rate of adherence to ticagrelor in this study was quite high, considering that it is a twice-a-day medication, and other studies have reported low adherence. This sub-study was done for mechanistic purposes by Barber and colleagues who recruited 51 patients enrolled in the TWILIGHT study at their institution to undergo additional blood perfusion and platelet aggregation testing, both at randomization and about 1 month after that. For the 42 patients who completed the sub-study, they found no difference in ex vivo thrombus area between the study and placebo arms. There was no difference in thrombus area over time for both patients assigned to ticagrelor plus placebo or ticagrelor plus aspirin. No differences in platelet reactivity using either adenosine diphosphate or thrombin receptor activator peptide, but the ticagrelor monotherapy arm had higher platelet aggregation using the agonists arachidonic acid and collagen. Authors of this sub-study argued that this was physiologic corroborative evidence from the exact same patients enrolled in the trial that really supported the clinical conclusion that when you withdraw aspirin, it does not appear to lead to more thrombotic events, at least while you maintain ticagrelor. Though several experts have called the results of this trial practice-changing, I'm not sure if that is truly going to be the case here. I think it's fairly well established that ticagrelor increases the risk for bleeding compared to monotherapy, especially as you may know from the recent THEMIS trial that I described earlier in the last episode. An appropriate control may have been monotherapy with either aspirin or a different P2Y12 inhibitor. This study adds additional complexity to multiple different trials which have to some degree shown differing results when it comes to outcomes. And this study kind of mixed up or put together patients with stable disease, asymptomatic patients, those with unstable angina, and those with NSTEMI into one trial. And I'm not sure if this trial is really powered well enough to look at these specific subgroups of patients, which we already know respond differently to antiplatelet agents. A remarkable study that was presented in the New England Journal of Medicine in October of 2019, really 3 weeks ago, looked at targeted temperature management for cardiac arrest among patients with non-shockable rhythm. It's called the CRICS trigger set group. Not sure if this is really a very catchy name for the group, but what this study looked to do was to look whether moderate therapeutic hypothermia, which is currently recommended in patients to improve neurological outcomes, especially adults presenting with persistent coma following resuscitation from an out-of-hospital cardiac arrest with shockable rhythms, which we know has randomized control evidence supporting improved outcomes. This kind of studies were never really done in patients with non-shockable rhythms, those being asystole and pulseless electrical activity. So if you've been taking care of patients for the last few years, these arguments have been made several times when we go for hypothermia in certain non-shockable patients. And the question comes up, are we doing something that actually benefits this patient? Is there any evidence to support what we do? It's important to note that hypothermia was profoundly beneficial in patients who presented with out-of-hospital cardiac arrest with shockable rhythms, with persistent coma, and improving neurological outcomes. The number needed to treat as good as 6 for 1 improvement in outcome. It begs to question whether this benefit would persist among those who present with non-shockable rhythms. The confusion was compounded by the fact that prior retrospective case series showed beneficial effect of hypothermia. They showed no effect of hypothermia, and other studies or other series showed actually harm of using hypothermia in patients presented with non-shockable rhythms. This trial really needed to be done to settle a lot of these uncertainties. One, because non-shockable rhythms predominate patients with cardiac arrest and are associated with a very dismal prognosis, with only 2 to 15% of the patients having good neurological outcomes compared to the nearly 65% of the patients who have cardiac arrest with shockable rhythms. That's a significant difference. Additionally, data on moderate hypothermia protocols was limited in patients with cardiac arrest due to non-cardiac causes or in patients with in-hospital cardiac arrest. So the trial we talk about is called the HyperIon trial. It was performed to assess whether moderate therapeutic hypothermia at 33 degrees Celsius when compared to targeted normothermia being 37 degrees Celsius would improve neurological outcomes in patients with coma who had been successfully resuscitated after cardiac arrest with non-shockable rhythm. The trial was supported by independent research from the French Ministry of Health and non-profit healthcare institutions and foundations. None of these funders had any role in the trial design, data collection, or analysis of data and writing in the manuscript. The candidates selected for the study were 18 years of age or older and had a Glasgow Coma Scale of less than or equal to 8 at presentation. Now, according to French law, because the strategy used in both groups were considered to be components of standard care, informed consent for trial participation was not required. That made it easier to do this study in France. However, French data protection authorities required that patients be given the opportunity to decline that their data be used. If the patient couldn't give consent, it was required that the closest available relative receive specific information about the trial enrollment. Now, several patients were excluded from this trial, and this becomes actually probably more important when you're trying to apply this data. Patients who had a no flow time, which is basically the time from collapse to initiation of CPR of more than 10 minutes, were excluded from this trial. Patients who had a low flow time of more than 60 minutes, which is basically initiation of CPR to return of spontaneous circulation, were excluded from the trial. those with major hemodynamic instability, which is significant doses of pressors, patients who had a large screening time from cardiac arrest to screening being more than 300 minutes, patients in a moribund condition, patients with significant cirrhosis of the liver, those who were pregnant or breastfeeding, patients under guardianship, patients being an inmate at a correctional facility, previous inclusion in a randomized control trial involving patients with cardiac arrest in which neurological outcome at 90 days was assessed, those with lack of health insurance, and those with decision from the next of kin to not participate. These patients were all excluded from the trial. It's important to look at the duration of hypothermia. So the hypothermia group really had achieved a temperature of 33 degrees by 6 to 8 hours of initiation of hypothermia, and then they started getting rewarmed around the 24-hour mark from the start of treatment. And most of these patients were back to normothermia by 40 hours. The primary endpoint of this study was a favorable neurological outcome assessed on day 90 after randomization using the Cerebral Performance Category Score, the CPC score, which ranges between 1 and 5, 5 really being death and lower scores indicating favorable neurological outcome. So a CPC score of 1 or 2 on day 90, basically indicating a favorable neurological outcome, was present in 10.2% of the patients who underwent hypothermia compared to 5.7% of the patients who underwent normothermia. The absolute difference really being 4.5%, coming to roughly a number needed to treat of 22 patients. It is interesting and important to note that there was actually no difference in the overall mortality at 90 days or death in the ICU, these numbers being remarkably alike. Really no difference in the length of stay in the ICU or survival to ICU discharge in either group. I think what this study basically showed that yes, you did have a favorable neurological outcome if you received hypothermia, post-cardiac arrest, and persistent coma from a non-shockable rhythm, but the effect is much lesser than what we've known before among patients with shockable rhythm, nearly having to treat 3.5 times more patients to achieve a similar benefit. And moderate hypothermia basically improved the neurological prognosis, but did not affect survival at 90 days. If you compare the number needed to treat here to other modalities like using bystander CPR or using epinephrine in our ACLS algorithms, you could actually argue that this is a therapy that probably has more benefit because the number needed to treat for one additional patient to survive with a CPC score of 1 to 2 is 22 for hypothermia, like we just said, compared to 15 with bystander CPR to prevent 1 death, or 112 with epinephrine. It is a number that may be reasonable depending on the clinical resources available to a healthcare system. Maybe we could possibly get a score out of this to enable us to understand which patients were the ones that actually benefited, helping us to individualize our decision making. There was another ICU study that I found quite remarkable. This is not truly a cardiac study, but I think it still has applications in potential future cardiac studies. This study looked at the effect of vitamin C infusion on organ failure and biomarkers of inflammation and vascular injury in patients with severe sepsis and severe acute respiratory failure. It was called the CITRIS-ALI randomized control trial. The authors tried to see whether intravenous administration of high-dose vitamin C reduced organ failure scores and reduced biomarkers of inflammation and vascular injury among patients with sepsis and acute respiratory distress syndrome, or ARDS. What they found in this randomized control trial of 167 patients in the ICU was that using high-dose vitamin C infusion for 96 hours in the ICU compared to using placebo resulted in no significant differences in the SOFA score, which is the sequential organ failure assessment score at 96 hours, or in the levels of C-reactive protein and thrombomodulin at 168 hours, really being 7 days. The conclusion was that among patients with ARDS and sepsis, high-dose vitamin C infusion compared to placebo did not significantly reduce organ failure scores or improve biomarker levels. However, there was an interesting secondary endpoint that came out to be positive. And while this study was somewhat smaller and not powered to look at an absolute difference in mortality, the study did find that absolute mortality rates were actually significantly lower among patients who received vitamin C compared to those who did not. The authors do say that this was a purely exploratory analysis, and they found that at day 28, mortality was 46% in the placebo group compared to 29.8% in the vitamin C group, p-value of 0.03, absolute difference of 16.58%, really coming down to a number needed to treat of 6. This study was a phase 2 trial. The expectation would be that though the primary endpoint was negative, the fact that absolute mortality was so significantly different between these two groups, it is certainly possible that we will see a larger phase 3 trial powered to look at the endpoint for all-cause mortality and the use of vitamin C. The reason I think there is some application in cardiac patients, especially in patients that you're dealing with significant vasoplegic components of shock in the setting of cardiogenic shock, or if you're looking at post-cardiotomy shock with significant vasoplegia following cardiac surgery, including patients who receive LVAD. The good news is that there's absolutely no significant adverse events that occurred in this study that were attributed to vitamin C. For a therapy that seems somewhat inexpensive and really minimal to low risk with potential benefits, I think it's something that we should definitely evaluate and research in these cardiac patients who experience significant vasoplegia. It is possible that this was just a chance finding because the primary endpoint, which was really the mechanistic endpoint as to why we think vitamin C works, why we think it actually decreases inflammation and inflammatory biomarkers will be reduced, was all really negative. We don't truly know why patients would benefit. Clearly, I think more to come here in this field of vitamin C therapy in vasoplegia and septic shock. The last study I would like to mention very briefly was the initiation of statin therapy during childhood among patients with familial hypercholesterolemia. These were 20-year results, 20-year follow-up results of statins in these patients with familial hypercholesterolemia. The study used an approach to use their unaffected siblings as controls without hypercholesterolemia and their parents as controls with hypercholesterolemia not receiving treatment. Familial hypercholesterolemia is a fairly common autosomal dominant disorder of lipoprotein metabolism. It is most commonly caused by mutations in genes encoding key proteins involved in the LDL receptor, endocytic and recycling pathways that lead to decreased cellular uptake of LDL cholesterol and subsequently increased plasma cholesterol levels. So these patients really had severely elevated plasma levels of LDL right from birth, and these patients are known to be very high risk for premature coronary artery disease or cardiovascular disease. Currently, we know we have more treatments available for hyperlipidemia, including the PCSK9 inhibitors, which are very potent. Statins are still the first line of pharmacological therapy in patients with familial hypercholesterolemia. They had 214 patients with familial hypercholesterolemia, genetically confirmed in 98% of the patients. These were patients who had previously participated in a placebo-controlled trial evaluating the 2-year efficacy and safety of using pravastatin. These patients were invited for follow-up and together with 95 unaffected siblings. The participants completed a questionnaire, provided blood samples, and underwent measurements of their carotid intima media thickness. The incidence of cardiovascular disease among the patients with familial hypercholesterolemia was compared with that among their 156 parents. The mean progression of carotid intima media thickness over the entire follow-up period was 0.0056 millimeters per year in patients with familial hypercholesterolemia and 0.0057 millimeters per year
in unaffected siblings who acted as controls. The mean difference between the groups was marginal.
The cumulative incidence of cardiovascular events and death from cardiovascular causes at 39 years of age was significantly lower among the patients with familial hypercholesterolemia than among the affected parents.
The affected parents thus serving as controls for having the disease but not actually getting treatment in form of statins.
Number really being 1% versus 26% for cardiovascular events and 0% versus 7% for death from cardiovascular causes. The authors concluded that initiation of statin therapy during childhood in patients with familial hypercholesterolemia not only slowed the progression of carotid intima media thickness, but significantly reduced the risk of cardiovascular disease in adulthood. The mean LDL cholesterol in these patients had decreased from 237 at the start to 160 milligrams per deciliter, and this was a decrease in 32% from the baseline level. The true treatment goal was to achieve an LDL of less than 100, only achieved in what looks like 1/5 of the total population, really only 20% of the patients. Now, you could argue that there was some participant attrition leading to loss of power and potentially inducing a bias in the study. Data on vital signs was obtained for all patients in the original cohort, and data on cardiovascular events was obtained for 95% of the original cohort. Approximately 85% of the cohort had in-person follow-up visits as part of the present study. Because almost all the known reasons for non-participation were not associated with the presence of familial hypercholesterolemia or the outcome measures, the authors believe that the risk of attrition bias in this study was quite small.
This highlights the importance of aggressive LDL control in these patients, including potentially using PCSK9 inhibitors to get to targets.
And once they actually come into the market for commercial use, the siRNA inhibitors, which can be given once every few months and have profound decreases in LDL levels. So starting early seems to be a good idea. I think this is consistent with other data where instead of using a spot LDL level check,
we should be looking at the total time of exposure to elevated LDL, which likely correlates better with outcomes.
And our goal should be to reduce the LDL, stabilize your plaques as soon as possible. That's all the studies we have for today. I hope you enjoyed it. The next few episodes we have will be heart failure with expert interviews. And we have some great interviews lined up in the field of sudden cardiac death and heart failure. We have a cardio-oncology series that we've started already working on with several great experts nationwide. And these talks will be coming to you very soon in the next few weeks. So that brings us to the end of another episode that we had a great time creating. Thank you so much for listening. We appreciate your feedback and your reviews, and we are constantly working to improve our content and make it very applicable in practical day-to-day use. If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestion for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links to all the podcast providers where you can listen to this episode. You can find us on our Facebook page at HeartSuccess Team, or you can always reach me on Twitter at CardioBro.